Hey, good morning, everyone, and welcome to UroNurse. We meet every Saturday at 9 a.m. Central Time, and I'm coming to you not from my home. I'm in Florida, sunny Florida. So, welcome to the show everywhere we can take it on the road. Glad to be here. Hey, if you're watching us on YouTube, LinkedIn, or Facebook, welcome to the show. And great announcement. We did it. We hit the 1,000 mark on YouTube. So now what's that mean? It means I've become a YouTube creator. So it's got some other things it opens up for me to be able to do on YouTube. But thanks for everybody for subscribing. We got to that number a lot faster than I ever thought we would, but it's been great. So glad that we do it. Hey, but keep subscribing. I think there's other things that can occur as that number goes up. Also want to make an announcement. So we're now going to be on X. We're going live to Twitter. So whether you call it Twitter or X, I don't know. It's called X to me now. But we're going to actually be streaming this episode going live on Twitter. So if you're on Twitter, you'll be able to watch it. And you can watch it on demand at any time on Twitter also. And last week I said we're going to try to go to Instagram. We did try, but we failed. So it will be on Instagram today. I did check it. The feed is working. The Instagram is the only one that it doesn't keep a feed for later. So you can't watch it on demand for Instagram. But you can go to our website and you'll be able to watch it in whatever your favorite format is and see us there. Also, I'd like to thank our sponsors that made this show possible. And I would like to give a shout out to the Glido folks, Sage and Pharmacal, who just renewed for a second year and went up to a gold sponsor. So, hey, thanks a lot for doing that. Also, if you're watching us and you want to hit the comment box, again, everything except for Instagram, it doesn't work on there, but all the other comment box should be live and we can see them on the show. So feel free to use that. And if you're not getting the newsletter, I don't know what you're waiting for, but go ahead and hit our newsletter up on our website to get that. First time here, great. Glad to have you here. Be sure to check out UroNurse.com to learn more about the show. And it's also the best place to go to find all of our past episodes. And boy, we got 71 of those past episodes. Also, want to listen in your car? I just took a 2-day car ride getting here to Florida. So I had plenty of time to listen to my podcast. But you can go to the UroNurse Plus area, sign up for any of your favorite formats, and listen to us in your car. It sounds great. So let's bring in our experts here. I'm going to go ahead and do that right now. Hey, welcome, everybody. Welcome to the show.
Good morning.
Got everybody on, so that works out good. Doing this remotely, it's always a little bit of a challenge, but at least driving, I was able to go ahead and bring in my big computer with me. So some of the other equipment's still back home, but I'm working with it. This and that seems pretty good. That's why the background's different. So we're going to do a little different introduction, but I'm going to start out with my introduction. But what we're going to do is I've got a question for the audience this time. So, whoops, I bring that up here. So that's what our question will be instead of a makeup one. So anyway, I'm Vic Sinise. I'm the host and producer of the show. Been in urology for 40 years and loving every minute of UroNurse. Now, my favorite Christmas story is actually going to be this one that's being created right now. Christmas has always been about family for me. So getting together with the family, we've got a big family. And in the years past, we've had personally hosted the Christmas Eve party at my house. And I had a huge house, so it was good to do that in. But we've had like 70, 80 people over for Christmas Eves. It's always been great. But now a lot of the family has moved. And I think this is pretty common for a lot of us, that family has gone everywhere. So this year I decided I'm going to go to Christmas because my oldest son lives in Florida. Go to Florida for Christmas. 6 of the grandkids are down here. So I thought we'll just try that out. Well, it turns out that not only is my son out here, my daughter's coming up. They're driving down, I guess. I always get it wrong. And I also found out that my siblings, I'm the oldest of 5, 4 of us are all in Florida together. So we're going to be getting together, all of us together tomorrow as a big family. And a lot of the nieces and nephews are there. And I think that's why there was so much traffic coming in. It was just the Sinise family coming in for Florida. So it was really neat, but that's my favorite story. All right, Andrea, go ahead and do your introduction.
Good morning. My name's Andrea Strong. I'm a nurse practitioner in Wisconsin. I'm also the educational director for the Chicago Metro SUNA chapter. I'm on the board of directors for National SUNA, and I'm certified as a urology registered nurse. And I'm also coming to you remote from Chicago. So we're visiting family here for the holidays. My two nieces are here, and I'm so excited to see them. Favorite Christmas story? Well, mine's a little bit urology related. So last year, a patient came in, and I don't remember what year this SNL skit was from. Maybe someone does, but the sweaty balls skit on SNL. It's a classic. If you haven't seen it, I highly recommend it. So he comes in and he's wearing a Sweaty Balls Christmas sweater. And I started laughing. I was just cracking up. And he said, I knew it. I knew it. My wife said, you cannot wear that Sweaty Balls sweatshirt to the doctor's office. And he said, yes, I can. Yes, I can, because it's urology office. It's urology office. And he was absolutely right. He could wear that sweater to our office. Everybody loved it. He was the star of the show.
That's a great story.
Favorite Christmas stories as it pertains to urology.
Absolutely. Hey, John, welcome to the show.
Thanks for having me.
Yeah, glad to have you always.
Let's start with the favorite Christmas story. Many of you know that I'm an immigrant, so I came to the States. We did not really do this Christmas celebration thing. So I remember vividly, I was invited to a Christmas gathering, Christmas Day, actually. And I was dating someone way too young for me. But anyway, I went to her family's Christmas Day celebration, Christmas Day opening of the presents. And at that time, I had no idea that's what people did. Everyone sat around and he went around and opened presents in sequential order. I had never done that. And I was in my 30s. So that was eye-opening for me. And now, of course, my kids do it. My family does it all the time. Everyone opens presents sequentially. Okay, the kids get one, the second kid gets one, the third kid gets one. I had no idea that was the case. That's what people did. So that was very interesting. And it always reminds me that we have to be aware of where people came from, because their cultures may be different. And we can't take for granted that's because everyone else seems like they all do the same thing, that these other people who came from a different culture do the same thing. So we just have to be aware of that cultural difference and be sensitive to that, I guess. So a short introduction, private practice urologist, just a lowly urologist here in the Phoenix area. And what I do is try to help other urology practices achieve the economic and practice efficiency that they deserve so they can live a easier and happier life.
Yeah, absolutely. Great having you on board. So we're going to get on with our show here. Really interesting show today. I think we did this, or I know we did this last year, where I did this hunt for old or new products that have come up in urology. So I really scanned the net and try to find everything I can. So I'm going to be sharing that with everybody today. So let's go ahead and bring in that slideshow. Should be fun. So we'll get your comments. Feel free anytime you have a question to put those through. But let's hit our new urology product review. And I'm going to start with this one. I kind of like this. It's a bioreactor, which is going to be kind of a mechanical kidney, so to speak. The latest advances in this form of implantable bioreactor that includes a type of kidney cell from the proximal tubule cell, which is used to regulate water levels, as a proof of concept. So a bioreactor is designed to be directly connected to nearby blood vessels, allowing blood to flow through it. However, silicon membranes protect the kidney cells within from immune attack. So far, the device could support cell survival for at least 7 days when bioreactors were implanted in pigs, suggesting that the technique could work when additional cell types are included. So the goal is to produce this as a kidney transplant. I've got a little clip on that.
Kidney failure, which affects about 600,000 people in this country, is treated either by dialysis or, better, if you can get one, is a kidney transplant. Unfortunately, less than 10% of the people that need a kidney transplant can get one. There are just not enough organs available. I'm Shuvol Roy. I'm an associate professor in the Department of Bioengineering and Therapeutic Sciences. This is our lab, and we are working on an implantable bioartificial kidney to free the patients from the burdens of dialysis, provide them improved quality of life, and hopefully, if we do this right, okay, we'll actually have something that's going to cost less. than the current therapies today. Now, we know that the technology to get there exists. We're taking that infrastructure that California has become famous for, and we're applying it in a way that's not been applied before for medicine. I try to communicate the excitement that we're taking semiconductor technology and applying it to medicine in an unprecedented way. So a current dialysis machine is the size of a refrigerator, and the key component in that is a dialysis cartridge. There's about 2 square meters of surface area. To get the same amount of filtration, we need 1/20th in the silicon filter. So we take these membranes, cut them into those squares. We test each of the individual membranes for how do they perform in terms of filtration. We challenge it with water and particles in the water that are very small, and we see how much water comes out and what particles come out. And Steve here is basically helping test the performance of this filter in a little cartridge. This information then gets fed back to the people that are helping us on membrane design or people who are helping us on surface modifications. We'd like to make sure that blood doesn't clot in silicon. So here I work with Zohora to basically take the membranes we have and we can coat them with special molecules that make them blood friendly. 3D printing is a big step in sort of helping us prototype. You can design different versions so we can look at it. Part of engineering is you got to look and feel. Is it the right size? Can a surgeon implant that? We're testing and optimizing each of those components individually to make them as best as they can be and then eventually bring them together. So what we have here is the prototype model. This is fake blood. Coming out here is our fake urine. In practice, we won't need a pump because the silicon membranes are so efficient that our body's own blood pressure will be able to drive the filtration. And I feel excited when you're making progress. When I hear from patients, when I hear from physicians, when I hear from students, when I hear from the other engineers that we can do this. Look at the impact. There's 600,000 people who have kidney failure in this country, 2 million worldwide. Less than 20,000 transplants are performed every year. And on the waiting list today, which is the sickest of the sick, there are almost 100,000 people. If we can deliver on this, we can provide an alternative therapy and a treatment option that doesn't exist today for the vast majority of people who are now forced to rely on dialysis.
Pretty interesting. I was just surprised. I take it personally because my father was a renal transplant patient. He had renal failure and was lucky enough to get a kidney, but there was a couple of years that he was on dialysis, and it was a big change in his life. But have anybody heard of that before? Yeah,
No, it sounds really exciting. And if they can make it in such a small package and eliminate the big dialysis machines that we're so used to seeing, boy, it would be life-changing. Possibly, the thing is, I'm thinking, what if the patients can do that themselves? If they can access the ports, I don't know, that may be the next step. And then after they use it, just simply dispose of that.
Yeah, I mean, it's just mind-blowing to think that they can come up with some of these things. So, all right, we'll get on to our next one. And this is on something called bacteriophage. I remember this when I was back in college that they started talking about these phages. They're viruses. Antibiotic resistance has complicated the treatment of many infections. Bacteriophages represents a completely different way to treat infections, with these viruses displaying a highly specific ability to target one type of bacterium, unlike antibiotics, which we know are broad spectrum. And as a bonus, there's a bioluminescent signal that these phages have been engineered to express so they could be tell when they've encountered their actual target bacterial species. So kind of another way to diagnose infection. Again, I got a little film on that. Yeah, that one's almost scary. My next one is something called acoustic-powered micro robots for bladder disease treatment. And what this is a delivery system. These things are tiny little propellers that can be made to move around by applying acoustic energy, sound waves. And they spin around dispensing a medication. In this particular study, they were using dexamethasone for people with irritable bladder syndrome, the IC types thing. Anyway.
Institute for Intelligent Systems in Stuttgart have designed and fabricated an untethered micro-robot that can slip along either a flat or curved surface in a liquid when exposed to ultrasound waves. its propulsion force is 2 to 3 orders of magnitude stronger than the propulsion force of natural microorganisms, such as bacteria or algae. Additionally, it can transport cargo while swimming. The acoustically propelled robot has significant potential to revolutionize the future minimally invasive treatment of patients.
That's crazy. I mean, I can imagine these things carrying, cancer drugs and everything. So it's really wild. Of course, AI has always been fascinating, and we've talked about several different uses of AI, but AI is going to be getting into everything. And here's a prostate cancer use. The goal behind the system is to effectively treat the tumor, but preserve as much of the healthy tissue as possible, thereby maximizing patients' chances at retaining full urinary and sexual function. The ablation technology itself is laser-based, and the system is intended for use with just a local anesthetic and as an outpatient procedure in the clinician's office.
Prostate cancer affects 1 in 8 men, but the challenge isn't just diagnosis. It's also about locating the cancer accurately for effective treatment and preservation of quality of life. Traditional MRI scans won't show you the whole picture, leaving doctors and patients in a difficult position. That's where Unfold AI steps in. Developed by Avenda Health and backed by over a decade of NIH-sponsored research at UCLA and validation from Stanford, Unfold AI is the first FDA-cleared cancer mapping and decision support tool specifically for prostate cancer. Our technology utilizes multimodal data, combining MRI, biopsy, pathology, biomarkers, and patient demographics. This comprehensive approach allows doctors to visualize accurately cancer within the prostate to make treatment decisions and deliver more precise care than ever before. Why is multimodal AI crucial? Just like humans rely on multiple senses to understand the world, our AI system uses multiple types of data to make complex decisions. This enables doctors to go beyond human limits in cancer care, with the aim of reducing the risk of both overtreatment and undertreatment. The result? More accurate cancer margins, a higher likelihood of preserving critical structures, and ultimately, a better quality of life for patients. Unfold AI isn't just a product, it's a revolution in prostate cancer care. It's about giving doctors the tools they need to make the best decisions with their patients. It's about seeing beyond the image and choosing treatments that are right for you.
Yeah, that's pretty interesting to see what's coming up. And AI, can it replace a radiologist? So we talked about that AI kind of being one of these things that may take over different jobs. I think the surgeons got it pretty safe. Nurses probably a lot of the hand-on jobs, but these things where you have to look at something like a film, a pathologist looking at cells, those things could be replaced.
This is how a radiologist diagnoses pneumonia.
84-year-old female, shortness of breath period, frontal and lateral views of the chest period.
This is an algorithm called ChecksNet that's trained to do the exact same task. And this is how it performed against 6 doctors analyzing 50 chest x-rays for pneumonia in a recent test at Stanford. ChecksNet is one of many projects exploring how artificial intelligence can take over tasks normally done by doctors. And it has some radiologists worried that AI could one day replace them. That's because algorithms are getting really good at interpreting images and diagnosing disease, sometimes with greater accuracy than humans.
We'll take a picture of this X-ray. The model will then run, and within a few seconds, it's outputted all these diseases, and they're sorted by the order of most likely to least likely.
ChecksNet was given tens of thousands of images and told which ones have pneumonia and which don't. Then it trained itself to recognize patterns and identify pneumonia in new X-rays. This process is called deep learning. In 2016, computer scientist Geoffrey Hinton, also known as the godfather of deep learning, put radiologists on notice.
People should stop training radiologists now. It's just completely obvious that within 5 years, deep learning is going to do better than radiologists.
Hey, I'll throw this to the panel. What are your thoughts on AI replacing physicians in the future? I'll start with John, since he's a physician.
Yeah, so I think about this all the time. So when it comes to cognitive stuff, AI depends on good, valid information. And sometimes it's difficult to get that information out of the patients. And I think it requires someone who thinks in the spot in front of the patient to ask the right questions. I'm not sure if AI is there yet and able to elicit these questions and to be able to read the patient about uncertainty, about distrust, and things like that. So I think that's still going to require human-to-human interaction. But every single day, when I'm seeing patients, I'm thinking about how do I eliminate myself? How do I make myself to not have a job anymore, right? So I perform the SWOT analysis in my practice every single day. And when it comes to performing vasectomies, I tell patients the hardest part of a vasectomy is not actually doing the procedure, but finding the vas deferens. Every scrotum is different. You can have obese patients with difficult scrotums. You can have an obese patient with an easy scrotum. The ability to feel and identify, isolate, and say that this is where I need to work, what I need to work on, that is not going to be replaceable by AI given current technology, because it requires feel. And I don't think there are any good tactile sensors. And I don't know if I entrust my scrotum to a machine to smash at different intensities just to find the vas deferens, just to experiment with that. So in that sense, doing vasectomies, not going to be replaced by a robot anytime soon in my lifetime. But something else, cognitive sciences, when it comes to looking at radiographs, or looking at skin lesions, looking at pathology, yes, they are definitely very much at risk.
Yeah, I agree.
Yeah, I agree, John. And we have a comment here from Katie Bortel, and she agrees, John, on that. From a nursing perspective, there is something about human intuition. And I know we've all felt it before. We've talked about it. It's that nursing intuition. And I don't think that any AI can take over that aspect of things. But some things computers are better at doing than we are. And if that means that the patients are safer and the diagnoses are more accurate, then I'm all for that aspect of things. But in general, I don't think we're there yet with replacing our jobs.
And I don't think a computer can offer compassion, at least at this point. Well, do a good job of, but because I've seen where, a patient will say, "Oh, that doctor is so great." And it's really because the doctor actually, took the time to listen to the patient and explain things and cared. I've been lucky to work with a great group of docs, and one guy in our group, I tell you, as a person to deal with as an employer, he was a real SOB, but the patients loved him because he cared. Every patient was that important. And he always said, he says, treat your patients like they're your family. Hopefully you like your family though, right? But that was his whole technique, and it really showed through. And I think that's going to protect our jobs for a while. Who knows?
And for the docs and the nurses who take care of patients, sometimes showing that care is very simple and it's very subtle. Yeah. For instance, one way to very easily show that compassion, the care that you're listening, a couple of things. Number one, sit down when you actually are in the exam room instead of standing, holding onto your tablet, your notebook computer. And secondly, that tablet and notebook computer is a barrier between you and the patient. That screen that you have up between you and the patient is a physical, literal barrier between you and the patient in order to communicate with the patient. That's why I don't see patients with a computer screen in front of me. I use a tablet, just like the old time charts. You have a tablet or a piece of paper or a clipboard that you're just simply writing things down. So that's the way I do it. But a couple of different ways that you can easily bridge that gap between not caring or being seen as not caring versus a compassionate, caring physician.
Yeah.
I agree, John.
Even writing down like what patients tell you during the exam, like, "Hey, I'm going to Florida to see my kids." The next time you see the patient, he comes in and you say, "Hey, how was your trip to Florida?" That's a big score for compassion.
Mm-hmm.
And you don't want you want to. Okay, this is something. I'm coming in here tomorrow because I saw patients recently who are older patients. They're widows, and they have told me that they're going to be spending time during this season alone. And of course, it takes a little bit of probing because they'll bring up, oh, I lost my wife, etc. And I'll say, oh, do you have any family nearby? So what I did was I wrote down not their names, but their patient numbers. So just to be compliant, I wrote it in a secure place. And what I'm going to do is I'm going to come in here tomorrow and I'm going to call them to tell them, hey, you know what, somebody's thinking about you. Because a lot of times, I also see a lot of police officers and they tell me about the depression that happens around this time and the calls that they have to respond to. So it's not something that you can do that doesn't cost you anything, but it makes a big difference in a patient's life.
Yeah,
it
good
does.
point.
And I did just see some research. We're getting a little off topic here, but I think that's
all right.
okay. I did just see some research that indicated that loneliness is a greater risk for mortality than smoking cigarettes. So it's really significant and heartbreaking at times. So I think it's wonderful that you're going to reach out to your patients.
You can have all the AI innovation, but then you also need to come back to the basics of just interacting with patients, compassion. Also, AI is not going to be able to, as far as I know, AI is not going to be able to pick up pheromones that are released by humans. That, Andrea, you said the gut instinct, the sixth sense. Well, I think a lot of that sixth sense is from being physically close to the patient, and you're picking up the vibe, if you will.
Yeah.
From the patient, the hormones that we naturally release that is picked up by another person.
Yep.
So that's not going to happen yet with
discussion.
AI.
And it's kind of how I decided to do the talk, was to break in and bring you guys up throughout. So don't mind being open with suggestions. I think this is where we all kind of learn more. That's why you guys are the experts. All right. My next thing here is, hey, got one of these myself, the Apple Watch. And whatever monitor you're using, I think this is going to be another big step towards early detection of medical problems.
Number 1, patient monitoring. AI-powered wearable devices are the future of healthcare. They utilize a combination of sensors, data collection, and advanced algorithms to continuously monitor patients' vital signs. These devices are typically worn on the body and can measure various parameters, including heart rate, blood pressure, oxygen saturation, and activity levels. One notable example is the Zeo patch by iRhythm, which is specifically designed for monitoring heart rhythms. The patch contains built-in electrodes that capture the electrical activity of the heart. The collected data is then processed and analyzed using AI algorithms. These algorithms are trained on vast amounts of data and employ machine learning and pattern recognition techniques to identify irregularities in the heart's electrical signals. When the AI algorithms detect a potential cardiac arrhythmia, the wearable device sends alerts or notifications to healthcare providers. This real-time information allows for prompt intervention and appropriate care. The benefit of AI wearable devices lies in their ability to provide continuous monitoring outside of the traditional bedside setting, enhancing patient safety and outcomes. Furthermore, the AI algorithms continually learn and improve over time as they're exposed to more data. This iterative learning process enhances the accuracy and efficiency of arrhythmia detection, reducing false positives and false negatives. Additionally, these devices can collect additional contextual data, such as activity levels, sleep patterns, and environmental factors, providing a more comprehensive understanding of the patient's overall health.
Yeah, I think this is really going to be huge as these algorithms start to learn more and more about us. They get more data. They'll be able to detect things far quicker than what we've ever detected before. Hey, we talked about doctors losing their jobs. How about nurses? Yep, they're looking at robotics to replace a lot of the tasks. Now, I don't think, again, the nurses probably have to worry, but some of the assistants, floor assistants that were doing a lot of the task type orientation things, you might be out of a job someday.
We created Moxie to support healthcare workers in dynamic and ever-evolving clinical environments.
Moxie is a mobile manipulation robot that moves seamlessly and safely to perform a large variety of useful tasks. Moxie fetches and delivers crucial yet routine items within clinical environments, like lab samples, medication, PPE, and so many other things that clinicians often find themselves running around to grab for their patients. Moxie can even navigate secure entrances, elevators, and automatic doors. Designing Moxie has been an incredible experience for our team. Seeing the work Moxie does in hospitals drives us to continually push to advance our AI and manipulation technology.
What do you guys think? You want to see one of these running around your hospital?
I think it needs to move a little bit faster if it's going to be running to get me a supply in an emergency situation.
Yeah, I don't know about for use in an emergency, but certainly for mundane tasks and delivering specimen, things like that. I'm not sure if it'll deliver anything that may harm the patient, such as drugs, right? I don't think the Pyxis is going to go away. But maybe they can design the robot so that they have individual compartments, and once it reaches the destination, verifies the identity of the person interacting with Moxie, then it'll open up the correct drawer.
Yeah,
maybe.
True. I'm sure they're looking at all these different techniques, but I think a lot of like delivery of specimens and things like that typically I can remember I started out as an orderly, and one of the jobs I would have to do is run down to central supply to get supplies. I mean, it was just a lot of useless running back and forth.
Oh, I started as a volunteer delivering schedules, different departments. So that is all electronic now, but imagine mundane tasks and manual tasks like that. You can do, or somebody in the ER needing an 18 French Coude catheter or 22 French Coude catheter, right? So you can send Moxie to go down to the OR, grab it, and then bring it right back to you in the ER while you attend to another patient.
Yeah, so it'll have a use. All right, now this is my favorite one that I found, and it doesn't exist in America. It's called the Sheelan catheter. It's for giving a local block to the prostate without having to go transrectally. So watch this one here. Like I said, this blew me away because we do a lot of resumes and urolifts. So you just do standard technique for putting in a Foley catheter, put your balloon in, and it's got an injection syringe built right, or injection port right into it. You can drain the bladder through it. And like I said, urolifts, resumes, those type of things are ideal. Whatever you want to inject into it, you can see how this works. It's got, you can decide where you want to inject. You go in there, you stick one needle stick through it, inject, pull back to the next line, inject again, couple cc's, pull back to the next line. You're giving 3 injections through the same site, unlike when you do transrectally where you're probably going multiple sticks. Again, you just switch over here. They're going to that 4 o'clock position, go in deep, inject, pull back a little bit, another 2 cc's, inject, pull back a little bit, another 2 cc's, inject. And then finally, you see that big line, you're safe to move it to go to your other injection sites up here at the 11 and 1 o'clock zones. There they just give 2 injections, one on that side, one on the other side. There we go.
Boy, I have so many concerns with that.
Well, that's why I put this thing out there, because I'm thinking, first of all, getting out of the rectum, that's great. You don't have to put somebody through a transrectal ultrasound to do the local block. Everything's done transurethral. So go ahead, John.
I hope somebody's aspirating first before injecting, right? It's unlikely that you're going to be injecting directly into a vessel, going transurethral injection into the prostate. Also, how do you know how much to stick in? Obviously, hopefully, you've done a transrectal ultrasound, so you know how big that prostate is. Because I'm doing minimally invasive surgical treatments on varying size prostates, sometimes even under 20 grams. So you have to know how large that prostate is, also how long that needle is sticking out. I also worry, you've done this before. You think that the coude is going in one orientation, but then what you do out here may not correlate with what's happening at the distal end.
Yeah.
So how do you know when you turn here that the needle is actually going at the 1 o'clock position or 3 o'clock position? So those are some of the concerns. Anyway, good idea. I like it.
Yeah.
I just wanted to take this opportunity to highlight some of our comments here.
Sure.
So Katie said AI will augment the diagnoses effectiveness. Charlene said greetings from Springfield, Illinois.
Hey, Charlene.
And a Merry Christmas from Taiwan. It's
Wow.
11:30 p.m. there. So good evening and Merry Christmas.
It kind
That
of
is
blows me
awesome.
away. Yeah. At the reach of this show, the number of countries. We'll talk about that next week at our show, is what we're getting out to in some of the different countries. But hey, thanks for that.
It's interesting because I just did a video. It's going up on YouTube soon. I just did a video in the Thriving Urology Practice Facebook group using one of the idioms from Taiwan, and it goes something like this: 腾口棒腿. So what that means is somebody's taking his or her pants off just to pass gas. And the analogy is that you're doing things inefficiently. You're making more work than you need to accomplish a task.
Yeah.
Anyway, welcome Taiwan.
Our multicultural, multi-country program. All right. This next thing is I just was going through again. We always talk about these biofilms and how they prevent us from treating infections because of them. So there's some research going on where they're finding plants in Africa called the Gisho plant that actually has a ability to break down these biofilms. So I'm interested in watching this research develop and see, because I think that's going to have a lot of utilization for urology for sure. And next, I'm going to switch over to what things we've done in UroNurse with new inventions that have been brought to light. So I thought it might be fun to share some of those real quick with everyone. In episode 35, we had the WellSpec group come in here with something called the L, a little change on the female self-catheterization. Here's that.
We have the Lofric L. The Lofric L is our newest female-length catheter. It was launched in May of 2022, and I'll show you the steps to using Lofric L. So the first step is to lift this top to release the seal, the pressure, and then we'll twist to release the integrity seal, and then we'll separate the catheter, take the catheter out. And the container portion has some wetting solution in it. So that's important to know. For this purpose, I'll keep the wetting solution in here. This container is recyclable, which is very nice. There are two little buttons at the bottom. So you twist the buttons into the circle on the side. So it's a twist and click. So again, it's the bottom of the container that is twisting and clicking into the Lofric L. So it's in the shape of an L.
Already, I didn't want to go into that one right away, but I guess it did. But I thought that was kind of a neat take on, anyone who's done self-catheterization instructions on females. It's always a kind of a more difficult thing to do than for us guys who are lucky. I thought that was just kind of a cool little subtle change to the catheter.
Yeah, and something else that is available, I think, from a lot of the companies, maybe Coloplast or Bard, a lot of these companies will have a lighted mirror, if you will, because for a female, they have to kind of not be able to visualize their urethral opening and try to put a catheter into that opening for self-catheterization. So if there's a mirror that they can use that is lit, right? Kind of like I guess a lot of the YouTubers or video content creators, they have a ring light.
Oh,
so
yeah.
imagine a ring light mounted on a mirror that you can place down there, and then it'll make it a lot easier for the female, for the woman, to find that urethral opening. That's also available, and often that is for free, but you can also find it on Amazon.
Absolutely. All right. Our next was episode 43. Another invention for ladies, because we've had external catheters for men, but now there's one that's available for females called the UriCap.
Urine collection device. UriCap Female is a simple, comfortable, and quick-to-use device that enables effective urine management. The UriCap Female is assembled from the cap and the tube. Connect the cap to the tube. Connect the tube to a urine bag. Make sure they are firmly connected. Apply the lubricant around the edges of the device. clean the vaginal area before applying the device. Hold the urocap female with your dominant hand. Place the index finger in the longer lower lip of the device. With your non-dominant hand, spread widely the inner and outer labia. Locate the top of the vaginal opening. The device is placed in the area above it. Attach the long or lower lip of the device to the vaginal opening. Using the free thumb, tip the cap upward to make full contact with the area around the urethra. Lightly push in and hold in place for 5 to 10 seconds. Close the inner and outer labia around the cap. Only then remove your dominant hand. Fasten the tubing to the securement device where the extension piece meets the drainage bag. Allow enough slack in the tube and secure to the inner thigh.
Also, one of the things that we've been fortunate is to get a lot of the creators of these actual products into the UroNurse world to talk about their products. And in episode 45, the creator of the catheter leg bag underwear joined us to talk about how he invented this and how it works.
What I invented was Cathwear, this medical underwear designed for this patient population. Cathwear is a medical underwear that is washable, machine washable, and machine dryable. But the key features of it are Cathwear removes the use of the Velcro straps. So now the patients no longer have to utilize the straps. They can put the pouch in a 600 or smaller pouch system here, which does not restrict the flow of the urine. It has a valve that opens up at the bottom to create easy access. So if you're wearing shorts, skirt, or a dress, you'll be able to just access the valve and empty the contents into a collecting receptacle without having to remove the pouch. The X-looking feature that you see is a catheter channel tract.
We've had a lot of programs that have dealt with the newest technology for BPH, and they've been super popular on the show. I know besides healthcare workers, I think a lot of patients are looking for these. And I thought I'd run through some of the ones that have really been popular, like the aquablation therapy.
So how does aquablation work? So it essentially uses high pressure water to resect the prostate. Think of it as almost like a water saw. But it's done extremely precisely using robotic technology. And so what do we mean by robotic technology? So first of all, there's real-time image guidance during the procedure. So you're going to have cystoscopic real-time imaging as well as transrectal ultrasound real-time imaging to give you kind of the multidimensional view of the treatment area while you're resecting the prostate. This allows, personalized treatment planning. We use a software during this procedure where we map out exactly the contour that we want left behind of the prostatic fossa and what areas we want resected. And we can change that treatment plan based on the patient's importance towards sexual function, ejaculatory function, and symptom relief. So, and here you see the aqua beam kind of working, and it kind of sweeps high pressure water against the prostate. And you see a live cystoscopic view of this as well.
The other thing that we also talked about with BPH was something called the OptiLume, which is a technique with using a balloon.
And so now enters OptiLume BPH. So this is taking that technology that we had from the stricture device and applying it to the prostate. So it comes in a standard box. And what it's going in that box is going to be a couple components. One is something called the pre-dilation balloon. And number two is going to be the drug-coated balloon. And then, of course, there's going to be a pressure gauge to actually increase the pressure by connecting it. So this will become a little bit more clear in a moment. This is what the OptiLume balloon looks like. So for those who are just listening, I'll describe it. It's essentially a double balloon. It looks like in the old days, there was actually some double balloon type of Foley catheters. So it's a double balloon and it's inserted into the bladder and then it's pulled back. The furthest balloon is actually going to sit in the bladder. And the second more distal balloon is going to sit in the prostate. And it's sort of shaped like a figure 8 or two bubbles. And where those two balloons meet is where it's going to lock into the bladder neck. And so there were actually balloons designed for BPH called the Dow balloon in the late 1990s. And there was a lot of excitement and fanfare around these balloons. But the problem was that, number one, there was a lot of migration. They would slip forward into the bladder or slip back because they didn't lock into place. And two, they just didn't have durability because they kind of stretched the prostate, but they didn't fundamentally change it. And of course, there was no drug coating to prevent the prostate from closing down again.
And in episode 61, not only do we take in balloon a prostate and water jet it, we can also take this wire called the iTIN device.
So what is the iTIN procedure? So iTIN is a new minimally invasive therapy that works by with no energy delivered, no permanent foreign body. So essentially the device is implanted. We could see this over the marked areas of one, device implantation. The device is placed inside the prostatic urethra. Over the next 5 to 7 days, the device expands, creating incisions at the 12 o'clock, 5 o'clock, and 7 o'clock position. And then in 5 to 7 days, the device is completely removed, leaving nothing behind. So the device is essentially placed in the prostatic urethra in a folded configuration, and then this expands over 5 to 7 days and then completely removed. So this is just cystoscopic view. So we can see example one, where you've got this high bladder neck, right? You can see how when you're looking into the bladder from the prostatic urethra, you can see how there's no view directly into the bladder. And after removal, you can see how there's a clear channel going inside the bladder.
Now, that's not a completely exhaustive research on all the different things we offer for BPH, but I thought those were some of the highlights. Now, this was an interesting episode 56 where I heard about this thing called the Lumia prostate biopsy system from a UroNurse who had written in on the UroConnect. I asked her to present on it, and that's actually how Lace got involved with the UroNurse.
Something we really liked. For our nursing staff, it was also great because, as you can see, those come pre-labeled. Of course, depending on your practice and what samples you want to take, your label might be different. And in the back of those, you just put your patient information. So I do have here with me, and I would love to show you guys. So usually your kits come in a lovely little box like this, and I have mine open already. When you open the box, you find yourself with these little Mylar bags. Of course, this one is open already, but this is what you will be sending your sample back in. With that right there, you find your board. It comes in this nice little plastic container here, so really minimal exposure to formalin as well. You go ahead and open this guy, and in there you find your actual biopsy board. So you see here, not only is this board labeled with the R for the right side, but it's also a different color than the left side, and also a different color from the additional board that you can use.
And again, on episode 59, we had the creator and inventor of this Ellatone external pelvic floor therapy, who came up with this device to treat her own problem when, after having pregnancy, developed some incontinence, and this is what she came up with.
So Ellatone is the only non-intrusive treatment for bladder leaks anytime, anywhere. And I say non-intrusive in that not only is it physically external and non-vaginal, but it's non-intrusive on their time. They don't have to schedule time to just sit, or be flat on the back for 20, 30 minutes. So it's composed of a device, a small controller. I'll hold one up so you can see kind of how tiny and little it is, about the size of a matchbox, really. Rechargeable, and gel pads. And these gel pads are super thin, about this, as thin as a paper. And let me just show how flexible it is. So it's flexible and comfortable. And these gel pads are reusable and then disposable. So we have Ellatone for the stress incontinence, and just this year, Ellatone Urge for overactive bladder. Now, to give a little bit more detail on this, this gel pad has adhesive hydrogel, and that's the conductive areas. That is essentially we're delivering electrical stimulation through the perineal tissues.
And then most recently, episode 71, we had this device for an external catheter that could be used for both men and women. And this one kind of blew me away because it was one of the few I've ever seen that's reusable, that could actually stay on for men. Most of them fall off. So here's that one.
So again, the true catheter, we're going to show you, we have multiple catheters. We have modified the male catheter multiple times, and we have a catheter that's bigger, and then we have a catheter that's smaller for the males. And we have a female catheter as well, which Christine has over here. This is the female catheter, which again is a little different because it has, if you will, more of a shaft in there. And then we have a pediatric catheter, both pediatric female and a pediatric male catheter as well. And that's what this is the first, just as somebody who spends a lot of time in pediatrics, the fact that we're able to have an external pediatric catheter is very exciting for us. When we look at this catheter, there's several, you can read, there's several components to it. But one of the things that's very interesting is that this catheter you can actually apply yourself. So we have people who are putting this catheter on. We have a CEO of an organization that uses this catheter every night. He applies it himself.
And that is it for my tour through different new exciting inventions that have come up and things that we've had on the show. It's been a great year. It's been a wonderful year for me to try to learn about all these new things. I think it's just I have this thirst for knowledge, and I always enjoy learning more new things. So just think what's going to happen next year.
I can't wait.
All right. Do we have any questions or comments coming in from the audience?
Don't see any questions or comments yet, but while we're waiting, I was thinking of one of my many favorite Florence Nightingale quotes. And there's one that's just perfect for all this innovation and everyone creating everything in healthcare just to try to make it better for the patients. So this applies to more than nursing. This applies to the entire healthcare field. And that is nursing is a progressive art such that to stand still is to go backwards.
Yeah, absolutely. And this, the thing about urology that's always been fascinating for me is it's just such a fast momentum of change that you just can't sit back and say, okay, I learned everything I need to know now.
Yeah.
It's amazing how many new inventions. I mean, even trying to guess what's going to be next is almost impossible.
Yeah, I was just reflecting on that recently, how I put in ureteral stents in the operating room, how I perform TURPs now in the operating room.
Yeah.
It's just so different than when I was trained.
Yeah.
We have two comments that came through. We have a Merry Christmas and a Happy New Year, and always well done at UroNurse.
Wow. Well, thanks for those compliments. Great. Well, I'm good with being pretty close to done here. So I'd like to take a little time out here to talk about next week's show. Next week is going to be a look back at 2023 for UroNurse.
As we reflect on the year 2023, a glance back at UroNurse.com reveals a dynamic and evolving platform dedicated to serving the urology nursing community. Throughout the year, UroNurse.com has been a reliable source of information, education, and community engagement for urology healthcare workers around the globe. UroNurse.com has facilitated a sense of connection and collaboration among urology nurses. The year 2023 has seen UroNurse.com continue to be a vital resource, reflecting its commitment to empowering urology healthcare workers and ultimately improving patient outcomes. Join us December 30th at 9 a.m. Central Time on UroNurse.com.
All right. Well, we look forward to everybody joining us for that show. It should be fun to kind of look back at what's gone on in the past year in UroNurse. It's been wild. It's been quite a ride. And hey, you guys are really what makes this such a success. I can't thank you enough for everything you've done on the show, giving your time every week to be a part of that expert audience, to talk to the experts who come on as our guest experts. Have a very Merry Christmas, everyone. And hope to see everybody again Next week, it will also be remote. I'm still in Florida, but luckily I got good internet at this place.
Excellent. Well, thank you all for watching and listening.
Yep. All right. Goodbye, everyone.
Bye. Merry Christmas. Have a great New Year.